Hello, welcome to Understanding the Hypermobile Universe. I'm Bonnie Southgate. It is May 2026 and it's EDS Awareness Month, and I am going to bring you a presentation today specifically on the head and neck and all few conditions that may affect people with symptomatic hypermobility. So if you enjoyed this talk, I will be posting this video on my YouTube channel, hEDS Rehab, and I will be following this talk with specific exercises that go with it. And I will then continue from the head and neck down through the shoulders, the spine, the thorax, the hips and pelvis, knees and feet. So if you like it and you're interested, if you do subscribe, then you will be notified when new videos become available. So a little bit about myself. I am somebody who has a diagnosis of hypermobile Ehlers-Danlos syndrome with morphonoid characteristics. I originally was a ballerina. I danced with American Ballet Theatre as a soloist and then later on the Royal Ballet as a first soloist. I left dance because I didn't know at that time I had EDS and I was troubled with injuries. So I then trained as a Pilates teacher. And I also trained then following that as a remedial sports therapist because I was interested in getting hands-on and having more knowledge. I'm trained in craniosacral therapy, which I do use a lot, especially in regards to the head and neck. I then trained in dance science. I have an MSc in dance science because I wanted to look at a bit of research in wonderful hypermobile dancers. And I've given lots of talks to all sorts of people. I wanted to give a shout out to a charity that I'm one of the MSK advisors for, which is SEDSConnective. And it's the first charity that linked hypermobility and neurodivergence. So it's a really fantastic charity. So I would say have a look at it and support this charity because it's a great charity. So before we start the presentation, I want to just say that this is not medical advice, that everything in here comes from either research that I've looked up or mostly from clinical experience. So obviously you always need to take the advice of your medical practitioner first. So looking at the head and neck, we're going to have a brief overview of the anatomy. So the cervical spine, which is your neck, is the most mobile region of the spine, and it consists of 7 vertebrae that support the head and the skull and all those structures that come inside those bones. So we know we've got the brain there, we've got the brain stem, we've got the spinal cord that comes down, and from the brain you've got some cranial nerves that come down, but the spine itself protects the nerves and blood flow vasculature. So it allows the passage of all the blood flow, all the cerebral spinal fluid flow. And all of these different soft tissues will contain collagen and be part of your connective tissue system. So there can be stretchiness or laxity in areas that can create symptoms and problems. So we're going to be looking at some of that more specifically as we go through this presentation. So we're first going to look at upper cervical instability, and between 52 and 66% of people with hypermobile type Ehlers-Danlos syndrome and hypermobility spectrum disorder are estimated to have mild upper cervical instability. Severe upper cervical instability, which can be extremely debilitating, is much less common at around 5%. So upper cervical instability is a term that encompasses both craniocervical instability, which is the photograph on the left, and atlantoaxial instability, which is the image on the right. So craniocervical instability, CCI, involves that top joint. So it's the atlanto-occipital joint where the skull actually meets your spine, so that first cervical vertebrae. And the movement, the primary movement at this joint will be nodding the head forwards and backwards. We call that flexion and extension. And this is your yes nod. And you can have problems with too much movement at this area or this joint. And you can also have a settling of the weight of the skull down on that first cervical vertebrae if you haven't got good muscular control. So in order to diagnose this, you would need some form of dynamic, which would be moving MRI or X-ray, because it's a movement issue. So if you've got issues in this area and you get a referral for an MRI where you're lying down, or something where you're not moving your head, then you won't be getting really appropriate imaging for this condition. And there's not enough dynamic imaging around. So unfortunately, people do get referred and don't get the diagnosis they need because of this. So Atlantoaxial instability, AAI, involves the next joint down. So this is that first cervical vertebrae and the second cervical vertebrae. And you can see this is an image on the right that is looking straight down from the top. And you can see that there's a peg where that first vertebrae spins around. So this primarily, the motion is rotational. So that would be your no movement of your head and neck. And it is approximately 50% of the next rotation. So you can see that you're going to have a lot of movement even if you don't have a hypermobility issue. And so it's primarily stabilized by ligaments that control it and hold that in place. And we don't want it sliding around because you can see where the gap is, and that will be where that spinal cord is going down. And we don't want to be impinging that in any way, shape, or form. So when your head rotates to one side, if you have too much movement in this area, you are in danger of compressing arteries, vasculature on the opposite side, so the contralateral side, and you can be overstretching and kinking the vascular flow. So the AAI can occur alongside CCI or on its own, and the symptoms do overlap, so sometimes it's difficult to know which is the cause of the problems. So when we continue with head and neck, we have to consider the jaw. So like other joints in the body, the jaw is affected by the connective tissue and its laxity, and temporomandibular joint related pain and problems is reported in up to 71% of people with EDS. So I think the figures are roughly between 33 and 71%, which varies depending on what type of diagnostic criteria they're using for the study of it. So the jaw and the upper cervical spine, really interestingly, share a nerve pathway that meets in a little relay box in the brainstem. And this is called the trigeminocervical nucleus. And there's quite a lot of research in this because of headaches and referrals of pain. So the fact that it's sharing one little junction box, and this is primarily for input from those areas. So if you think of we have something called afferent and efferent. It's the arrival of information that is relayed into this box from those areas. And then it has to sort of decide, the brain has to work out what the information is being sent in that area. And it can get a little bit of confusion. So what you can get is referred symptoms from one area to the other. So you can have tension in the jaw muscles, which can spread into the neck and shoulder muscles, affecting your head position and posture, but also your symptoms. So you could have persistent neck and shoulder problems that don't improve with neck treatment. And actually what you have is a jaw issue that's referred because it's gone to that little junction box and the brain's gone, we'll send some tension and pain to that area because we're really not sure what's going on, but we're going to protect the whole bit. So I know that research in this area that's been done would state that whether you have a jaw issue or a neck issue, that actually treating both of them together, the outcome is better. So I'm bringing up something called the meninges because we're going to look at some conditions after this that affect what we call the dura. The brain and the spinal cord are wrapped in three protective layers, and they're called the meninges. And the dura mater is the toughest outer layer, and it's made up of collagen. So if it's made up of collagen, it potentially could be altered in people with symptomatic hypermobility. So you can have stretchier tissue here. The arachnoid matter is the next layer, and it's like a little spider web-like middle layer. And then you've got something called the pia matter, which is a really delicate inner layer that clings to the spinal cord and the brain. And between that arachnoid and the pia is the subarachnoid space, which is where we get cerebral spinal fluid flowing around the brain and spinal cord. And this is cushioning and nourishing the nervous system, and it's removing waste from the brain. So it has a really important job at night. And the dura itself, which is that outer layer, is very rich in collagen, and it is very innervated. It has more vascular flow and innervation, so it can give you more discomfort, that layer. It's really there to support the brain and the spinal cord. And we're going to see how that interacts with the rest of the body, because it's not on its own. It does connect to things where symptomatic hypermobility can potentially have a little bit more of an effect. So we have something called the myodural bridge, which you may not have heard of before. And the myodural bridge is connective tissue that is a structure that links the deep muscles at the base of the skull, the suboccipital muscles, directly to the membrane, the dura of the spinal cord and the brain. So it will be coming down and feeding the top of the skull, the CO and the C1 and the C2. So basically that upper cervical area, all of those joints that we looked at earlier in this presentation, all have connections directly. So the muscles connect fascially into those vertebrae and the spinal cord. And so this is a really important thing when we're thinking about posture and we're thinking about stability of the spine. I think the focus traditionally on stability of the spine being only abdominal isn't correct. I think that may be on the bony level, but I think when we're looking at the spinal cord itself, we have this connection to the muscles at the base of the skull, which will be there to tension and release to support the dura and the spinal cord so that you don't get a disruption of the cerebral spinal fluid flow, which is just a really different way of looking at stabilizing the spine and the importance of our posture, which is where my MSK and my exercises come in, because I do believe very strongly that we can alter our overall symptoms by how we hold this area. And I know that the majority of my clients who come in with symptomatic hypermobility always complain of tension and tightness at the base of the skull, and often radiating into the neck and upper shoulders. And when we look at what we call coat hanger pain, I don't think people take this structure into account, and I think it's incredibly important. So this structure, the myodural bridge, also feeds into this trigeminocervical nucleus. So all of these structures all meet in this little relay box, the trigeminal nerve, cranial nerve that supplies the jaw, the vertebral C1 through C3. All these nerves come in and they supply information into this area. And then the brain's got to decide what to do. I like to have the image of the muscles linking into this around the spinal cord, holding it up a little bit like if you were holding a sock up or something, and they will be supporting that. And so one of the things, and one of the reasons the research says that it's there, is that if we were to nod our head backwards, we can get an infolding of that dura at that level where the skull meets the spinal cord. You can have an infold, and then it can stop that cerebral spinal fluid flow, which in itself will stop the flow. But when you don't have flow coming down, you also are creating pressure up. So those muscles will tighten up to support that tissue like a sock, so that it stays open as you nod your head back, they're contracting, they're keeping that open so that you keep that flow of the cerebral spinal fluid. So we can end up with tension in that dura, which is going to make us feel super tight. We're going to feel really tight all the way down the spinal cord, and it may create headaches and tension at the base of the skull and shoulders. And we may get very mixed up signals when this is all happening. So I've brought in something else because I think that this is another condition and area that gets confused with the upper cervical instability and probably the support for the myodural bridge. So it's known that around 10% of people with hEDS have what we call a Chiari malformation type 1. So there's different types of Chiari malformation, and this seems to be the one that is more prominent with people with EDS. It's a higher rate for female to male, and it appears to have an earlier onset than in the general Chiari population. So with Chiari malformation, if the skull isn't big enough, it squeezes it, and it squeezes it down into that hole, and then it stops or it compresses those structures that would be bringing blood flow, nerve information, the brainstem itself, and the cerebral spinal fluid. Now, with a connective tissue disorder, our brain is actually held to the skull through connective tissue. So in laxity and the weight of the fluid and the brain, you can imagine it could potentially sink down from the top of the skull. So I'm imagining that's why you may find the onset earlier in hypermobiles rather than the general Chiari population. So cerebellar tonsils, which is the base of the brainstem, herniate through that foramen magnum, obstructing CSF flow, compressing the brainstem itself. And the brainstem has a lot of functions, which will be motor coordination, voluntary movements, also your autonomic nervous system responses. So this could affect breathing, it could affect heart rate, all these different things. So when we are looking at dysautonomia and things like that, that could be from compression of the brainstem. The main symptom that is noted with this condition will be headaches. And again, we've got all this information coming into that little junction box, which is probably being compressed in this issue. So people will present with balance difficulties, proprioceptive impairment, guarding with those muscles at the base of the skull that will transmit tension again into the dura, all of the nerves of the body. So the nerves that come from the spinal cord into the arms, all the way down into the legs and the feet, every bit of them connect into the spinal cord. And that spinal cord is directly connected to the brainstem. So what I have found in my EDS Chiari population is that if you create tension in the nerves from anywhere in the body, it can be enough to increase symptoms. So if my shoulders hang, I'm pulling on those nerves downward. That also is pulling on the brainstem and the spinal cord. For one of my clients particularly, that was enough to bring on symptoms severe enough that she could no longer open one hand or have any coordination or support through one leg. Now, if we either did axial lengthening, supporting the skull up, or we lifted her shoulders up so they weren't hanging, it completely changed those symptoms so that she could actually open her hand and she could have support on that leg. So the exercises that I will be covering in this presentation can have some really dramatic effects on some of these conditions. So I brought in POTS, postural orthostatic tachycardia, into the head and neck, because really one of the big problems with POTS is when you end up with reduced blood flow to the brain and to the muscles around the shoulders and the head and neck. So the brain can't function very well without proper circulation, and it can again create headaches and some of the similar symptoms that all these other conditions we were talking about have. We can get shoulder, neck stiffness when we don't have blood supply. It's called ischemia, and it can be very uncomfortable. So head and neck in symptomatic hypermobility, we can see we have different routes that come to the same destination of issues. So looking at the craniocervical instability, we can see there's settling and excessive movement, which could cause altered blood flow, CSF flow disruption, brainstem compression, and neurological compromise. And then all these other things come back into this blue box with shared symptoms. So we can see how difficult it might be for our physicians to get the right diagnosis, especially when we are only allowed to talk about one thing at a time. So the musculoskeletal manifestations of the head and neck and dysfunctions also have shared patterns and some specific patterns. So the shared patterns will be those suboccipital muscles, which are those muscles at the base of the skull, and upper trapezius tension. So that's the muscles going from the neck down into the tops of the shoulders, tension, headaches, proprioceptive disruption, altered cervical motor control. So our coordination, proprioception may be altered. You might be dizzy. The other thing that I would say that I find, because I do muscle testing, and I often will find that my clients are globally what I'd call inhibited muscularly. So they feel a bit wobbly and weak when you ask them to resist very lightly, not strength. We're not talking strength. And then when we do some of the exercises or we do some axial lengthening, all of a sudden their muscles feel solid and strong. So my protocol for dealing with these issues is what I'll be sharing with you today. Condition-specific additions, reduced range of movement from muscle guarding, and poor coordination and balance difference with the Chiaris. The dysautonomia, you may have more exercise intolerance because it will affect the brain's ability to create energy, and therefore the brain may decide to give you what we call centralized fatigue, where if it's not happy with the brain's function itself, then it will shut down the muscles below in order to preserve what the brain needs energy-wise to keep functioning. And then we've got the TMJ dysfunction. And so we can have altered postures from the jaw and deep neck flexor inhibition. So that's the front of the neck, the muscles that sort of pull your jaw and your chin down can be inhibited. So I wanted to bring into this the influence of head and neck posture, because in all of these conditions, it will alter your function and your blood flow and potentially how much you move your head and neck. So if we look at the image on the left with the red dots, you can see that the upper back is quite rounded. We call this kyphosis. And when we are standing up, our eyes are programmed to always want to look straight forward. So the brain and the body will compensate for any postural changes down and that head position to look straight forward. So when we've got that curvy upper bit of the spine, that's going to alter our balance and our weight distribution. So in order to keep ourselves upright, the head will move forward, it will shear forward, and then it will lift up a little bit. So that position there, the head and neck is already in a bit of what we call extension of the neck. And so we already talked about the myodural bridge and the importance of the cerebral spinal fluid flow, and how when we lift our head up, if we have too much extension, we may have an infolding of the dura, and it may upset that balance of cerebral spinal fluid flow. So for the average person without a connective tissue disorder, it may not be a problem because all of those structures will be supported better. But with somebody with maybe too much movement or too soft a tissue, when they lift their, if they don't change the posture, they lift their head up, they're lifting it excessively, that might cause problems. And the reverse is true looking forward. So if I have a really flat upper back, in order to look straight forward, my chin will drop down and I'll be looking down. And then when I do things like look at my phone or anything where I've got to look down with my head, I might getting an excessive movement and be overstretching those structures in the back. and the brain and the body might not like that. And it also holds true for rotational issues. So if I was to have some form of rotational issue where my torso, say, looks slightly to the right, then my head would actually already be sitting looking to the left on my spine. And then when I go to look to the left, I might be excessively moving it because I can, because I'm hypermobile, and end up compressing vasculature on the right. So with somebody who has got symptomatic hypermobility or a really large range of movement, then we can say that our posture is going to influence function of all sorts of areas of the body that are important. So some of the exercises which I wanted to bring to your attention, especially if you're watching this and you have suspected upper cervical instability, are not necessarily suitable for the symptomatic hypermobile because you may end up shearing other vertebrae doing these isometric exercises like a chin pushing back. I have had many clients been given similar exercises, which again in the average population will be fine, but not in this population. So I just wanted to highlight those as there are probably better exercises to be doing. So exercise progression, my advice in working with AAI and CAI will be that you want to start extremely, and POTS, all of these conditions, very light or fairly light. So the exercises I'm giving should all be done with a light band to begin with, and then you can increase the tension of the band or weights as we will discuss. So stabilizing the neck without addressing the lower body, as we've looked at posture, will be futile because your head is so dependent on posturally on what's going on down below. I tend to like to start my exercises lying in supine if people are okay with that. Sometimes you can have too much fluid in the brain and you don't drain well, and those people will get headaches lying on their backs or not feel right. So obviously this is going to be specific to individuals. And if you do feel like it's difficult to do it lying on your back, that might be a little clue that you don't drain from the top quite so well. But generally, I would start people lying on their backs where they have support and you're taking posture out of the initial training. And then I would also recommend using little small Pilates cushions or bean bags where you can really support that cervical spine nicely without worrying about gravity taking anywhere where it shouldn't be. So it's worth mentioning aids for instability in this area. The Vista Aspen is a well-known good collar that people can use. Sometimes if I think people might have craniocervical instability but aren't particularly bad, then I'll suggest wearing a soft collar, especially in car rides, because movement of the body in a car or in a lift, that perturbation of the lower body can bring on symptoms, so it's worth wearing a collar in the car. You may have been advised that you shouldn't wear collars or supports because muscles might get weaker and they don't want that to happen. But as I discussed earlier, in people that have instability in this area or these different conditions, I have found that the muscles are switched off anyway. So you're not going to be using those neck muscles to support you until you have better positioning and less compression. Generally speaking, with the collars, they tend to need to be fitted professionally. And when you have symptoms which are relieved by wearing a collar, then I would start exercises wearing the collar, because you will be much more switched on to your musculoskeletal system from my clinical experience. So I start my exercises with TheraBands over the top of the head. I have it directly over the center of the top of the head, and I'm very much making sure that the alignment of my head, my vision is looking straight up, so my chin is not ducked or lifted too much. So you may need somebody to help you, give you feedback if you can't see yourself doing this, to make sure you're in the right place. And then we can start with some of the basic Pilates exercises this way. So what you'll find if you need these exercises is that if you didn't have the band over the top of the head and you were to say lift a leg, it might feel heavy. And when you use the band and lift a leg, that the leg might feel much lighter. And that would be a sign that you probably should be doing some of these exercises. One of the things that I've found on myself and other clients is that if you haven't done this before and you start to push that head up into the band, as you may feel a little bit of tension or a bit of burning coming down the spine, and this will be tension in that dura. So what I do is I do a little massage of those occipital muscles at the base of the skull, and this will all be in the individual videos. And then I do it again, and often that burning sensation goes away. So it's the tensioning of those suboccipital muscles that's pulling on the dura that creates that little sensation. So following on from this, I used to do in previous videos that I've given on exercises for upper cervical instability, I used to do the breathing first, but because of the compression of the brainstem being involved in breathing, I've swapped that around so that if we're in a better place with the cervical spine, then it may make the breathing actually easier and more beneficial. So I might start the breathing with the TheraBand over the top of my head. I just wanted to mention, especially because I work with a large portion of neurodivergence, that breathing has become the really popular go-to in helping to regulate the nervous system. So when we have lots of these issues, we can be in what we call sympathetic overdrive, or our sympathetic nervous system can be overstimulated, which is the run from the tiger part of the nervous system. And it affects all sorts of reactions in the body. So when your body feels threatened, it will alter blood flow, it will alter digestion, it will alter all sorts of things in the body. And we know that it's beneficial to bring us into what we call the state of parasympathetic in order to help calm the system and to have normal function. We should be able to be going in between sympathetic and parasympathetic. So breathing has really become the go-to, but what I have found is that quite a few of my neurodivergent hypermobiles will find breathing very anxiety inducing and having the opposite effect. So it can actually bring on more sympathetic activity. Very interesting information that is very specific to the brain is that carbon dioxide keeps the blood vessels in the brain what we call dilated. So it keeps them open. So if you were to hyperventilate, or if you were to do a long exhalation on your breathing, or even box breathing, and you are taking that carbon dioxide out and you're changing the levels of oxygen to carbon dioxide, where you have less carbon dioxide, what you may be doing is causing vasoconstriction, so a tightening of the blood vessels. So you might end up with less cerebral blood flow going to the brain. And I would say this for people with POTS, where they are struggling to get that blood flow back up to the brain. The last thing we need to do is to tighten the vasculature so it can't be perfused through the brain. So if you are somebody who's previously been given breathing exercises and you've really struggled with them, know that there may very well be a physiological reason for that. It's not just in your head. It's not just anxiety. You're not just being difficult, but your body may be reacting to vasoconstriction. So it doesn't mean you shouldn't breathe. It doesn't mean you can't do breathing exercises to reduce sympathetic activity. But what you do need to do is be careful to make sure your exhalation is not longer than your inhalation, or that you're not holding your breath. Anything that will change that CO2 oxygen exchange, you want to be regulating the inhalation and the exhale to be roughly the same length. So if it's 3 seconds in, it's 3 seconds out. And you may do much better with that type of breathing. I use the breathing also to be looking at the thorax to make sure that we have good ability to move different things. When we're talking about the upper neck and head, we mentioned that if you've got jaw issues or even with some of the upper cervical instability issues, if you're really tensioning those, if you've got a lot of tension in those muscles at the base of the occiput, you might be weak in what we call the neck flexors, which are the muscles in the front of the neck. And what I found is some people are so neurologically wound up that they can't really do anything touching the head and neck and the skull. But we can start doing some breathing exercises where we look at, can you lift the clavicle and the upper ribs? So the upper ribs will be attached to neck muscles, and a way of strengthening the neck muscles may be by accessing it through breathing, where we get those bones moving and focusing that way. Now, ideally, we know that diaphragmatic breathing is our most ideal way of breathing, but it is a way to access those neck muscles if you can't do it from the top down. So we can use breathing exercises in relation to the head and neck this way, but also looking at the fact that, do you only breathe up there? In which case, your accessory muscles, which will be those head and neck muscles, will be taking over the job of the diaphragm and may also be causing you problems. So we will look at this again as specific exercises in videos to come. So axial lengthening, sitting upright, starting to challenge our sitting posture, will be a progression from lying down. And then we add activity onto it. So we're challenging a little bit more, doing activities like challenging yourself sitting at a computer or maybe at the dinner table. So this would be considered a closed chain exercise where we've got that feedback coming down into the joints, which can really help with our proprioception. So we move from here on to taking the band away into more of an open chain exercise. So it's really repeating the same things with a book where we have more balance along with proprioception coming into it. And then we can increase the weight of the book, and then we can move on to weighted sort of bean bags that you can buy for the head to really strengthen the neck and stabilize it. So down the chain for me comes standing on a balance pad. If somebody's got instability at the top, I'm not going to challenge instability lower down because they're not going to have coordination to deal with instability. Or if they have, say, a Chiari malformation where they've got compression of the brainstem, you would not want to be putting someone on a balance pad. So this comes later in on the exercises where when you feel like you have more control through that head and neck and posture, then you can come onto a balance pad and you're challenging the head to respond to the movements down below. And then we also have proprioceptive training with laser training. And so we know that our eyes are part of our proprioceptive system. So we would start with the eyes open. You can buy these head lasers off Amazon and they're really good. And then you can start to turn your head in rotation to the left and the right, and you want to keep that beam nice and level so it's not wobbling all over, and then bring it back to the target. And you can do that up and down as well, and it gives you visual input into what you're doing in those motions. And then you can close your eyes and then see if you can come back to that target, see how well you've developed your proprioception through your exercises. So this is it for today. I've got references for you to look at. I hope you enjoyed this presentation, and if you did, subscribe and share it to people you think might benefit from it. And I really look forward to presenting you with some more information and the exercises that go with this talk.